these slides were adapted by Doctors Bot and Malay in the past, but these have been subsequently updated. I don't have any disclosures for today. Here are the objectives of today's talk. Really to understand and appreciate the substance use epidemiology as it relates to SUD screening, review current SUD screening recommendations, realize the role of screening as it relates to SBIRT, which is screening, brief intervention, and referral to treatment, review some current SUD screening tools, and then kind of show you all kind of how you would do this at your clinic if you're not already doing so, and giving you some examples of how to actually implement it. So here's kind of our roadmap to hit all those objectives, and we'll just jump into substance use epidemiology. So I think, I'm kind of preaching to the choir here, but substance use leads to more death and disability than any other preventable condition. Alcohol is the third leading cause of preventable death in the United States, and opioid and other substance-related overdose continues to climb. These numbers are kind of historical here, but they continue to go up each year. This here is the National Survey on Drug Use and Health, I think is what it's called, the NSDA. This is the most recent survey that came out in 2023. So these are the most updated slides and current information. But we're going to go through some of these for each specific kind of substance and kind of show you kind of what's going on there so you can get an appreciation of the epidemiology. So this is past month alcohol use, binge alcohol use, or heavy alcohol use. And you can see in this survey, there's about 135 million alcohol users, and about 61.5 million report binge alcohol use, and about 16.5 report heavy alcohol use. When you look at past year substance use itself, and this is not substance use disorders, this is just substance use for patients 12 and older, you can see that there's about 70.5 million people that endorse using substances in the past year. The majority of those are cannabis, and then it kind of went down from there on. You can see hallucinogens, pain reliever misuse like opioid prescriptions, cocaine, sedatives, etc. And then this is actually people with a substance use disorder. So again, these are patients not just with using the substances, but who have been diagnosed with a substance use disorder. And you can see in the past year, there's about 48.5 million people with a past year's diagnosis of substance use disorder. And when you look at these, you can see that alcohol use disorder is the most prevalent use disorder that there is in this survey, followed by a drug use disorder. I hate that nomenclature, but that does mean substance use disorder, not alcohol, marijuana use, pain relief, methamphetamine, stimulant, etc. I think this is the probably salient slide to look at here. These are people with a substance use disorder, so that same population we just mentioned, who were asked kind of if they felt they needed treatment or were interested in seeking treatment. So out of those 36.7 million people that they felt that they did not perceive the need for substance use treatment. And of those, only about 0.05% actually sought treatment, and about 5% did not seek treatment, but thought that they should get treatment, which I think is really important. And overall, the statistic here, again, is about 40 million adults with a substance use disorder did not receive substance use treatment. So why is that important? Well, number one, I think it shows that this is pretty prevalent, and we're not probably catching all these people, right? That's the thing, especially if they're not interested in treatment. It could be an opportunity to engage them a little bit better. And this topic is focused mostly on primary care, so people that would be performing screening for patients with substance use disorder or misuse. And when you look at the primary care setting, about 82.6% of adults and 92% of children actually see a healthcare professional. 55% of these 1 billion office visits are actually for primary care. And there's about 130 million ED visits annually. So there's a good place, if you had to pick a place to screen someone, I think these settings are an ideal way to do so. So why screen? Again, the prevalence is high, and you probably are seeing these patients already in your clinic and clinical setting. So in the primary care setting, about 24% of patients have risky use and 7% have a substance use disorder. In the hospital setting, about 17% have substance use disorder. And in the ED, about 11% of all visits are related to substance use disorder. So there's a high healthcare utilization for all these people. But yet there's actually literature out there to show that most healthcare providers are unaware of their patients' use. So how do we fix that? Well, one of those things is to actually start screening. So in addition to identifying people, the benefits of actually screening are multifactorial, right? So the first thing is if you can help identify these people, you can potentially intervene and help reduce their substance use, right? That's the big critical key component here. But overall, by doing so, you actually improve clinical care across the spectrum by doing this. So you improve patient safety, so you can help prevent withdrawal, drug interactions, et cetera, overdose. You can lead to a more accurate diagnosis. So why somebody has a hypertension, that's been uncontrolled could be related to alcohol use, for example. And if you're not treating the underlying cause, you're kind of missing what's going on there. Improve overall treatment outcomes. So not only are they doing better from the substance use perspective, but also their overall healthcare can generally improve once we start treating this. Again, you improve prevention like overdose, like I mentioned, but also infectious disease, particularly hepatitis C, HIV, et cetera. And you can actually appropriately target where these patients should be going once you screen somebody. So you can refer them to the appropriate level of treatment to give them a little bit more help if needed. The other thing that it does, though, is it actually, creates an environment that reduces stigma, right? So we can say that alcohol and substance use is important to general health and overall health. And if we start, in normalizing these screens and normalizing these discussions, I think you're also going to see this, wave of people being a little bit, hopefully, more transparent when discussing this. And it allows us to capture more patients and help more people overall. And then from, population standpoint, it really does help population health because we can start figuring out how many of these people have it, how we can start surveying them, and then really implement and design services to kind of help reach those people and help them, right? That's really the big goal here. So what are the current screening recommendations out there? So hopefully you all are familiar with the United States Preventable Task Force, the USPTF, as it's stated. They kind of generally give out recommendations for different things all across, what we do in healthcare. And they gave these specific recommendations a couple years ago, essentially for universal substance use screening and alcohol use screening for people ages 18 and over. So including pregnant women, these are also included in these screens. And these are both grade B. Well, it's not a grade A recommendation. Grade B generally means that the literature out there to support it is good or fair, but it doesn't actually cause any harm, right? That's the big thing here. By doing these screenings, you're eventually just identifying people. You're not doing any intervention that would necessarily cause any harm to patients, and therefore there's a grade B recommendation for this. And that's, again, for alcohol and substance use. So kind of what is the big kind of picture here of how this, works is that hopefully we perform this screening and then we can kind of determine, as I mentioned earlier, what that level of risk would be and then appropriately, refer and offer treatment based on what that risk level is. So if someone was a low risk, for example, you would just kind of congratulate them and not really have to do anything else. But if they were moderate risk or even moderate to high risk, you could offer an intervention or treatment. So that could be potentially for moderate risk, just like educational endeavors, maybe some motivational interviewing, harm reduction, et cetera. Same thing for moderate to high risk, maybe, offer them some treatment specific to what's going on. And then if they have a really high risk of dependency or use disorder, then you can either, move on to a more diagnostic assessment or refer them to specialty treatment when it comes to that, so they can actually get that treatment that they so much deserve. So how does that look like in practice? That's really what this SBIRT model is, right? Again, that's screening, brief intervention, and referral to treatment. And I'll say this, as a specialist, I'm usually on the receiving end of these kind of SBIRT things. I'm not really the one that actually performs this, but I can give you some kind of like outsider perspectives on how this could actually work. So really what it works, again, is the screening part. We're going to jump into that here. We're going to go through what those screening tools look like and what the different levels of those are. But that would be the first one, using a validated or standardized screening instrument to screen for substance misuse or use disorders. And then again, that can occur in any healthcare setting. And then based on what that level of risk is, you can intervene and refer to treatment. So the intervention, again, could be like having a conversation with them about their substance use or misuse and providing feedback specific to them on their use patterns. And then if needed, based on that risk level, referring them to treatment. And you could even escalate it to an additional, screening tool if you needed to, or based on the ASAM criteria, refer them to higher levels of care. Again, as I mentioned, I'm not as familiar with the brief intervention part, but these are kind of the steps, if you will, when it comes to brief intervention. And in summary, it's really providing information and feedback about the screening results, trying to understand the patient's views of their use and coaching them a little bit more on their perceptions about their use, encouraging patients to discuss their views on how their use led to whatever's going on in their lives, what they do or do not like about their use, and how they may consider changing, advising patients in a clear but respectful manner to determine or decrease or abstain from substances, and then teaching behavioral skills that will reduce substance use as well as chances of negative consequences, and then tying that all up and saying, hey, here's a follow-up for this patient. What are we going to do? And whether that visit is done via phone or another visit, it's kind of another encounter to make sure that you're going up on these interventions. And then the referral to treatment piece, again, it can be as simple as, moving on to a diagnosis and moving to those kinds of things, or depending on the severity of things, referring them across the continuum of care. This is just a broad strokes view of what the ASAM criteria are. There's different levels of care based on the risk of their use and the severity of their use, whether that means just an outpatient treatment center all the way up to, medically managed inpatient withdrawal. So it's kind of depending on where they fall across that spectrum and what actually their use patterns are, and if they're, in withdrawal, et cetera. I think it's important to talk about, so what is the difference between screening and assessment too, though? Because I think this often gets a little confused. Really what screening is what we, just kind of mentioned, is kind of just quickly identifying patients that may have misuse or substance use disorder. And it really occurs for patients that are just generally coming in to see you. You can screen them at that point, using a variety of settings. Again, it assists in that referral process to treatment and offering treatment. Assessment to me is really just diagnosis, right? So this occurs after the screening. So if somebody's a high risk for substance misuse and you think they may have a use disorder, that's when you actually do your assessment. That's when you do a history and physical. That's when you talk to them. You make that diagnosis based on the DSM-5 if they actually meet substance use disorder criteria. And then based on that, you work together to develop a treatment plan, offer them different treatment options, et cetera. When you look across the spectrum of substance use, misuse, substance use disorder, it kind of forms this pyramid, if you will, right? So at the very bottom is where people are not using at all, to the very top where they have a very severe substance use disorder. And then you have a spectrum in between that, usually kind of escalating in severity and consequences and use as it goes up the chain. And really what you're trying to do with these screening tools is identify kind of risky and problem use and even potentially substance use disorders if they screen high enough. But you're trying to find those people where you could potentially intervene on that need that help that would normally not be identified. So how exactly would you do that, right? And that's what these screening tools are. So when I think of screening tools, I generally think there's a whole bunch of them. I'm going to say that, and we're only going to cover a few of them right now. But screening tools can sometimes take a little bit of time, and they can be kind of low or heavy resource dependent. So do you have 15 to 20 minutes to go through this, or do you only have a few minutes to go through this? And being totally understandable, especially in the primary care setting where there's so many things you have to do, how do you add these additional pieces to what your workflow would look like, right? And I think that's important to look at. When you look at kind of these screens, I think of something that's really a low resource would be like just a general screen, right? So basically you're just asking, are you using anything, right? That's really the first question. And then based on what the answer to that question is, then you could move on to maybe, if you needed to, a higher level of screening or assessment, right? So what kind of things are you using? What's your level of risk, depending on what your use patterns are? And then if that's positive as well, and it shows increased severity, just like we mentioned before, depending on that risk, then you can move on to a more formal diagnosis and actually go through the whole criteria. So kind of looking across that spectrum is kind of the way I think about things. And just keep that in mind as we talk a little bit more about what these are. So I kind of broke these down into screening tools, again, based on that initial screen, and then a brief assessment, and then that potential diagnosis or assessment that occurs afterwards. And we broke them down by alcohol, substance use, or combined alcohol and substance use. So For alcohol screening tools, I'm just going to talk about two different things here. And the first one is the single item screening question for alcohol. And really, this is just one item, which usually only takes about 1 minute to do. It can be done via an interviewer, like you could ask this question, or it can be self-administered as well. And then depending on what that result is, and we'll talk about what that question is and how to interpret it, it may lead to this another more comprehensive brief assessment or screen, which in this case, the recommendations is an audit C, which is the alcohol use disorder identification test or consumption. And that's about 3 items in 2 minutes. Again, it can be interviewer administered or self-administered. So together you're looking at about 4 minutes there if everything was kind of slow to screen for alcohol use, depending on what their use history is like. When it comes to substances, again, there is also a single item screening questions for drugs or substances as well. Again, 1 minute, 1 item, interview or self-administered. And then depending on that, you could potentially move forward to what's called the DAS-10 or the drug abuse screening test. Again, this is specific only for drugs, not for alcohol. It's about 10 items and it can take about 10 minutes, so a little bit more lengthy. Again, can be interviewer or self-administered. And then you can do something that actually hits both alcohol and substances together. And one of those tools is something called the TAPS 1 and 2, which stands for the Tobacco, Alcohol, Prescription Medication, and Other Substances instrument. Depending again on someone's use pattern, it can take anywhere from 4 to 24 minutes, and it can be interviewer or self-administered. And we're going to go through each of these things too a little bit, but just to give you a broad strokes overview of what that is. So how does that play out into the resource dependency that we talked about previously? Well, if you look at these things, the single item questions and the TAPS 1, which is the first part of the 2-part TAPS, those are really low risk, low resource intensive, excuse me. You're just screening. Are they using, right? Single question, are you using or not? And then based on that, you'll move on to a little bit higher level, which would be the audit C, DAS-10, and TAPS 2. And then again, after that, depending on things, you would move on to provider assessment and diagnosis. So kind of this linear pathway moving up. I think this is an important topic, just as an aside really quick. Sometimes people ask, is urine toxicology an effective screening tool? And the answer quite simply is no. I thought I'd make this pretty simple to understand there. Really, urine toxicology to me as an addiction medicine provider, it's really only testing for recent substance use, right? It's not testing for patterns of use, risk, associated with that, et cetera, those things that would qualify somebody for having a substance use disorder. And often these windows for the toxicology, especially urine toxicology, is very small. So you're only capturing a small time frame in someone's history of what their use pattern may be. So these are not really effective. Also, you can have false positives and negatives on these screens, which really don't make them a really good tool for determining if someone has a use disorder or misuse as far as screening goes. And just as a quick aside, these are the toxicology detection windows by type. You can see that they're very small. Sometimes, for cannabis, it can be a little bit longer, but you're looking for usually just a few days when it comes to use for most substances on a screening toxicology test. All right, so let's jump into these tests a little bit further. So what is the single item screening for alcohol? Really, it's a very simple question. And based on that, it's either positive or negative. So the question you'd like to typically ask is, how many times in the past year have you had 5 for males or 4 for females or more drinks in a day? So the test is scored positive when the response is greater than 0. So if someone says, I do at least this one time, you know that it's a positive test result, right? Or if they can't come up with a number, then you know that's probably a positive as well. And that's already been an effective screening tool, right? Same question here for substances, right? So you could ask somebody, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Same rules apply here. Positive when the response is greater than 0, when the patient states they're having difficulty coming up with the correct number, because it's usually greater than 0 at that point. So now you've effectively screened somebody for both alcohol and substances just with 2 simple questions, right? That can be easily asked by you or by self-administration. So I did include some QR codes at the end, or kind of at the corners of all these slides. So if you would like to look these up, it can be easy for you to do and implement into your practice. So this is an example that I found online. It asks these questions. similarly to what we just asked. And you can print this out if you scan that and give it to a patient and self-administer it. And then based on what that is, if it's positive, then the subsequent tests would happen, like we mentioned, or again, a little bit more brief assessment. So if somebody tested positive for alcohol in that single item screener, for example, you could use the Audit C tool to assess a little bit further on their alcohol use. Again, this is MD Calc, and it kind of has quick and easy buttons for you to press and ask the questions. So the questions on the Audit C are, how often did you have a drink containing alcohol in the past year, with a frequency number there? How many drinks containing alcohol did you have on a typical day when you were drinking in the past year, with a frequency number there? And how often did you have 6 or more drinks on one occasion in the past year? So you basically ask those questions, you click these numbers, and it gives you a score. And based on that score, it actually gives you recommendations on what to do next to help with the patient. Again, kind of following that SBIRT model. If somebody did test positive on the single screener use for drug use, the recommendation would be to use the DAS-10, which again is these 10 different questions here. Based on that, you would have recommendations as well. Again, these are both, you can both scan these QR codes. You can find them on MD Calc as well too. All right, and then, sorry about that. So the one that I would probably end up using if I was in primary care, if I was trying to do this, is this TAPS tool, which again does the screen as well as a brief assessment as well. And it does for both alcohol and all other substances as well too. If you scan this QR code, what's really cool is it actually is like an iPad kind of website, or like almost like an iPad app. And you just click on the bottom if you're the patient or the clinician, and you just start answering questions. You just click, push a button, and it starts going through the series of questions that are on this TAPS questionnaire. And I'll just show you, like, for example, you'll click the first question and it'll ask you, in the past 12 months, how often have you used tobacco or any nicotine delivery product? And then it kind of gives a frequency: daily, weekly, monthly, less than monthly, or never. And then based on that, it kind of has this tree branch kind of logic, where if it's pretty risky or high risk, it'll ask a secondary set of questions. And if it's not, it'll move on to the next substance, et cetera, et cetera. And at the end, you get a risk assessment of what's going on. For example, I clicked yes to the majority of opiate use kind of questions on here, and it gives you an assessment. So this patient, if they answered yes to the majority of those things, would have high risk for opiate use disorder. And it actually gives you some suggested actions on what to do based on that. So I think it's a really helpful tool to implement into practice if this was something you were considering doing. What are the best practices for actually using these, though? And this is based on some literature I found. Again, use validated instruments. The ones I just mentioned are just a handful of them. There are others out there if you Google them. But these are the ones that I've seen most commonly use in practice, right? The single item screener is often used as a general way to screen for folks. And then there's a corollary, more robust screening assessment that's done afterwards. Also, make sure when you're doing these things that you communicate to the patient that the goal of this is not to kind of catch you or anything. It's mostly to help them improve their overall general health. And sometimes you can put up posters, flyers about kind of what you're doing too in your clinic to let them know, like, you know, again, normalizing what the conversation would be like. You want to make sure that you ensure privacy during these conversations, so that way it's kind of HIPAA compliant, but also it kind of leads to an environment of sharing. Let them know what you're going to do once you find out these things, again, that you're only here to offer help. And then if you can, sometimes the test results are a little bit better if you let the patient actually self-administer these things, right? So if there's not somebody there and they can, you know, disclose this information privately, it can sometimes lead to better yield and patients feel like it's easier to answer these questions. But understanding that, again, if that's not possible, you try to integrate that into your existing workflow that you may have. If you already have like an MA or somebody else that helps out with these kind of screens, it might be a good idea to kind of integrate that into your screening process that's currently going on. So sometimes at clinics, for example, they will screen for depression with the PHQ-9. Maybe you could roll in one of these additional survey instruments at the same time, and just make sure that you really develop that relationship with them so they feel trusted when you're asking these questions. All right, so we went over kind of why it's important to do this, kind of what the SBIRT model is, and what those screening tools are. So how would you realistically do this in your clinic? I gave you some best practices. I found this really great tool. Again, here's a link for that QR code here, but this is put on by NIDA, which is the National Institute on Drug Abuse, and the Clinical Trials Network, which is a dissemination initiative by NIDA, in conjunction with NIDA. And really what you do, it's a really fancy, cool website. You click on it and you describe what your clinic setting is. So you say, my clinic is a primary care practice or a behavioral health practice. You describe what kind of people or what providers are available at your clinic. We have access to blank, and we do this and this. You kind of go through these, again, very iPad-esque clicking of boxes, and it'll give you a plan based on what your clinic is based on to how to do this. And it actually gives you tracking tools on an approach of it, how to monitor adaptation or adoption, excuse me, of this in your clinic practice. I mean, it's a really great instrument. And I think if I was going to implement this at a clinic, this is something I would definitely look at. And then there's also resources in there to give the citations needed if you're more interested in that. The other thing too is a little bit more information about SBIRT if you wanted to know this a little bit better about how to do it. And actually, again, the brief intervention part is something I'm not as familiar with, but again, you can look up. This would give you a great resource for that. And then I wouldn't be a private practice clinician if I didn't talk about reimbursement in some way. So the other piece of this is not only is it's good for the patient, but there can be reimbursement associated with SBIRT. Specifically for Medicaid, the national average just for doing the alcohol and drug screening test that we talked about is about $25. But if you actually do the entire brief intervention for up to 15 minutes, you can bill that for $50, and you can do them, I think, in up to 4 intervals. Don't quote me on that. I'm not a biller and coder. But again, it could be an incentivization for you to actually do this in your clinic and figure out how to integrate it into your current workflow. So in summary, again, substance use is prevalent, but it can be better identified in general medical settings using validated screening tools and referrals to treatment. Alcohol and substance use screening is recommended for all adults over 18, including pregnant women, by the USPSTF. Simple screeners and brief assessments like single item questions or the TAP score can be effective in detecting misuse and substance use disorders. And there's resources out there that are available to help you implement this process at your clinic and support you along the way. And these are a list of resources. Thanks so much. And for that, I'll open up to any questions anybody has.